Hi everyone, welcome to the Journal Club by NPT India. I am Ananya Rakesh Sharma. I am a lecturer at the Department of Physiotherapy at St. John's Medical College Hospital, Bangalore. Today I am presenting a review article titled Time Post-Stroke and Upper Extremity Stroke Motor Recovery Rehabilitation. It is a meta-analysis by Mehrabi et al. It is published in Neurorehabilitation and Neural Repair in 2025. Coming to the background of the study, motor impairment is one of the most common and disabling consequences of stroke, especially the upper extremity impairment. It interferes with ADLs, vocational activity, it increases dependence, and reduces social and community participation. Now, there are multiple factors that influence recovery of upper extremity, one of the most important being time post-stroke, if the patient is in acute phase, subacute phase, or chronic phase. As we know, acute, subacute phases are known as critical window period for motor recovery. Most clinical rehabilitation happens in these phases. However, research trials generally study participants who are in chronic phases. This review raises an important question: how time affects responsiveness to rehabilitation, as it might tell us generalizability of these findings across phases. So, the aim of this review is to examine how time post-stroke influences intervention-related changes in upper extremity motor recovery as measured by FMA upper extremity when compared to conventional or sham interventions in RCTs. So, different time periods, will the patient respond similarly? This review searched 5 databases till 1st April 2021. Additional studies through hand searching reference lists from Chapter 10 Upper Limb Interventions EBRSR. Database eligibility criteria was the study should be published in English, RCT or RCT crossover. The participants in the study should be above 18 years of age affected by ischemic or hemorrhagic stroke. Examined interventions should be for upper limb recovery. The studies were excluded if they were secondary analysis or long-term follow-up of an RCT. They use Covidence software. 2 independent reviewers did title screening, abstract screening, full text, and data extraction. Conflict resolution was through a senior reviewer. To be included from the database pool, the RCT should have FMA upper extremity reported with total score out of 66. Single intervention for upper extremity rehab in at least 1 experimental arm, conventional therapy or sham in at least 1 control group. The studies were excluded if the experimental arm has combination of 2 or more intervention. FMA partial subscores or upper extremity and lower extremity scores were presented together. FMA upper extremity is not reported in an extractable format. Data extraction was in the format of authors, year, title, number of participants in each study arm, intervention description and duration, control description and duration, time post-stroke, and FMA scores. Time post-stroke was described as time from stroke onset until initiation of intervention. Acute and subacute were clubbed together for 6 months, chronic more than 6 months. FMA upper extremity point measures and variability estimates were collected at baseline and either post-intervention and or changed from baseline scores. If available, change scores from baseline were selected over pre-post intervention scores. For intervention, all type of intervention used for post-stroke upper extremity recovery were eligible for the study. The risk of bias assessment were performed by this review. Coming to the statistical analysis was based on mean differences between control and intervention group with corresponding standard deviation and sample size. Mean difference was chosen as summary to quantify the effect size with 95% of confidence interval and p-value. Heterogeneity was measured through Q-test and I-square statistics. A random effects model was used. Coming to the results of this review, records screened were 5,408. Total number of studies included in the main database were 1,276. Total included studies in the final meta-analysis was 157. Acute, subacute phases, the number of participants were 3,792. In chronic phases, the number of participants were 2,753. A total of 17 unique interventions were studied across all time phases post-stroke. Of these, 8 interventions were studied in both post-stroke phases, 8 interventions were studied only in acute phase, 1 intervention was studied only in chronic phase. Coming to the risk of bias assessment, high risk of bias was found in 98 RCTs, unclear risk of bias in 54 RCTs, low risk of bias in 5 RCTs. The risk of bias domains that led to high or unclear risk were allocation concealment, blinding of participants in personnel, and selective reporting. Coming to the analysis part, acute and subacute, the studies, the interventions that had largest treatment effect for acute and subacute phases were RTMS high frequency, theta burst stimulation, and modified CIMT. You can see their confidence interval, pooled confidence interval is on the right side. The studies that had statistical significance were motor imagery, rhythmic auditory stimulation, RTMS, low frequency, action observation, mirror therapy, NMES, virtual reality, and robotic assisted training. Their confidence interval, pool confidence interval, is also on the right side. There are few interventions that cross line of no effect. One of them was TDCS cathode. Coming to analysis of chronic phase, the intervention that showed statistical significance was bilateral arm training, TDCS cathode, motor imagery, CIMT, virtual reality, sensory stimulation, robotic assisted training. Again, their pooled confidence interval is on the right side. The intervention which crossed the line of no effect was RTMS low frequency. Coming to the results part, where comparing of acute, subacute versus chronic phase, CIMT, motor imagery, and robotic assisted training was beneficial in both phases. However, it was more beneficial in acute and subacute. Virtual reality, again, beneficial in both phases but more effective in chronic phases. Mirror therapy, RTMS, low frequency only in acute, subacute phases. Bilateral arm training and TDCS cathode showed effect only in chronic phases. Coming to the discussion, interventions studied in acute, subacute phases produced greater improvement in FMA upper extremity than in chronic phases. Out of 1,276 RCTs that were eligible for the study, 53% were in chronic phases, 24% in subacute, only 19% in acute. Despite predominance of studies in chronic phase, most patients who suffer a stroke receive rehabilitation in clinics in acute, subacute phases. This discrepancy raises concerns regarding the generalizability of RCT findings from chronic phase and using them in the clinical practice. Given the substantial difference in FMA upper extremity improvement in acute, subacute, and chronic phases, many of the post-stroke upper extremity motor RCTs that are conducted in chronic phase again might undervalue the potential benefit of the intervention that might actually happen in the acute phase. Researchers might be inclined to conduct RCT in chronic phases because of ease of participant recruitment, fewer mediating factors in chronic phases because the patient has crossed the first 6 months. Inpatient trials may not always be conducive to rehabilitation trial. The patient cooperation, stability might affect rehabilitation trials. In addition to magnitude of change, it is also important to consider the nature of recovery. Prior work has raised similar assumption that similar FMA upper extremity gains reflect similar recovery process. In this context, the notable high mean difference, more than 9 points, observed in RTMS high frequency, theta burst stimulation, and modified CIMT may suggest that these interventions share similar mechanisms such as target neurostimulation, which enhances neuroplasticity, especially in acute and subacute phases. There were several limitations of this study. Only studies in English were included. Required the study to use FMA upper extremity, which might reduce the number of interventions available for analysis. Variation in scoring method or assessor training of FMA upper extremity could have induced the heterogeneity. Total score of FMA upper extremity doesn't always indicate which specific motor function contributed to improvement. If the improvement happened in shoulder, hand, where the improvement happened. Now, this may limit the ability to assess whether changes were meaningful. For future recommendation, they suggest analyzing FMA upper extremity subscales separately to better capture meaningful recovery patterns and intervention specific effects. To conclude, the analysis showed most interventions for post-stroke upper extremity rehabilitation had beneficial effect on improving FMA upper extremity score in acute, subacute and chronic phases. However, interventions studied in acute, subacute phases on average showed greater improvement in FMA upper extremity scores compared to those conducted in chronic phases, which fits with the understanding of time limited impact of neuroplasticity and raises concern about RCT continuing to be conducted in chronic phase and generalizability of such research. Coming to the appraisal, I use JBI critical appraisal checklist for systematic review and research. Now, in this appraisal checklist, the study scored yes on most questions, such as is the study review question clearly and explicitly stated? Yes. Were the inclusion criteria appropriate for the review question? Yes. Was the search strategy appropriate? Yes. Were the sources and resources used for search studies adequate? Yes. Were the criteria for appraising the studies appropriate? Yes. Was critical appraisal conducted by 2 or more reviews independently? Yes. Were there methods to minimize errors in the data extraction? Yes. Were the method used to combine studies appropriate? Yes. Was the likelihood of publication bias assessed? Now, this is the only point where the study scored no. Were recommendations from policy and practice supported by reported data? Yes. Were specific derivatives for new research appropriate? Yes. A lot of these questions, the answers are in the supplementary material of the study. Thank you.